And it really peaks around ages 8 to 12 is when parents, kind of what I was alluding to earlier is parents will say one tic will improve and then they'll have a gap and then another tic will develop. And they often use a similar phrase of like, it's almost like a new tic replaced the other one.
A child blinks repeatedly during a well visit. A parent mentions a new throat clearing sound that's been going on for weeks. They ask the question many pediatricians hear every year: should I be worried? Tics are common in childhood, but knowing when they're part of typical development, when they could signal Tourette syndrome, and when they warrant further evaluation isn't always straightforward. In this episode, we'll separate myth from evidence, explore the natural history of tic disorders, discuss common co-occurring conditions, and share practical strategies for counseling families with confidence. This is Charting Pediatrics. Joining us for this explorative conversation is Chelsey Stillman. She is a physician assistant here at Children's Colorado, as well as the creator and director of our Integrative Tic Clinic. She's also an assistant professor of pediatrics. Chelsey, welcome to the podcast.
Hi, thank you very much. Thanks for having me.
Yeah, this is such an interesting conversation. Let's start with some basics. What are tics and how common are they in kids?
Yeah, tics are really common. So tics are sudden, rapid, repetitive, stereotyped movements, usually presenting in a rostrocaudal presentation. So starting in the face and then gradually over time, usually over the course of like years, you can have tics that involve hands and even like trunk or feet. Tics are actually all vestiges of normal movements. And that's where, I've kind of relied on that a lot in my clinical practice, trying to figure out if a movement is a tic or something else. Tics are movements that we all of us do, but people with tics, chronic tic disorders, and Tourette's just do those movements quite a bit more.
And what is the etiology of tics and Tourette's?
That's a complex question. So there was an interesting article, and I'm forgetting who wrote it, but there was an article that looked at fellowship-trained pediatric movement specialists and asked them, I forget the number of how many they interviewed for this, but asked them if they felt like they could confidently report the pathophysiology behind tics, and only about 25% felt like they could. So I think that's probably to say that the etiology is probably polygenic and not fully well known. We know that part of it comes from the cortical, striatal, thalamic cortical network in the brain, which is just basically a fancy word for the part of the brain that controls kind of the stops, basically the gas and the brakes of movements, how much of movement is initiated and how much movement is suppressed. There's probably also a dopamine pathway. There are environmental factors and some genetic factors as well. But broadly, probably it's diverse. But in terms of frequency, it's very, very common. There are studies that say up to 30% of children will have a transient tic or a provisional tic, meaning like a tic that kind of comes and doesn't necessarily stay chronically. My favorite example of after I had started this clinic, I was reading to my daughter's kindergarten class, and it was probably maybe like a year after I had started clinic, and I was reading Walter the Farting Dog. And I was up there and I was like, going through the books, and I was just like looking at all these kids trying really hard to stay still. And I was like, I bet it's more than a third. Like looking at all these kids doing all these different movements. I was like, I bet a third is probably being, conservative. I think it's incredibly common. Now, there is about a third of kids will have a provisional or transient tic. And then about 10% of the population of pediatric population will have a chronic tic, which means a tic for more than 12 months. And then a subspecial, another even smaller portion of those folks will have Tourette syndrome, which is just a phrase for chronic tics. But one of those tics is phonic or vocal, meaning a tic you can hear.
So is it a continuum? You go from a conditional tic, transient tic, to a chronic tic to Tourette's?
Sort of. So that would be like kind of 3 different buckets that kids can present in. So to a degree, it's a continuum, but I sometimes review that with families, and that, because there still is a stigma with the word Tourette's, I'll often say, kind of present it in this way, just saying, hey, Tourette's is just a chronic tic disorder, one of the tics you can hear, to try to remove the stigma from it. But it isn't necessarily that they progress in that way. It's just some kids will have different severities of it to a degree. And some kids will have provisional tics and then develop chronic tics. So it just kind of depends.
And kids can present anywhere along that spectrum. Can a kid just come in with Tourette's?
Yeah, I mean, especially by the time we see them. So, I mean, it's not an uncommon story for me to see like an 8 or 9-year-old, and I'll say, well, tell me about when, did you ever have any eye blinking, throat clearing. What's funny about it too is like, it's so often that we ignore, not necessarily ignore, but we don't think necessarily about these movements as being tics, right? Like they are just funny habits that people do. And a lot of times by the time they come to see me, they're like, well, they kept blinking their eyes, and so we took them to the eye doctor, we took them to the PCP, and then we tried glasses, and it's like, okay, well, and then we realized like, hey, maybe this isn't something to do with their eye, because a child keeps saying that they have something in their eye, which is, an interesting part of tics is that there's an urge relief component to these movements. Now, young kids can't necessarily tell you that they have an urge into their movement. So like the eye blinking one would be an example of like a kid will say, there's something in my eye. When I blink, I feel better, but there's nothing in their eye. There's a physical feeling that they feel. And when they blink, the feeling kind of goes away transiently and then kind of builds up again until they have to blink, and that feeling gets better. You'll hear, again, another similar story is sniffing or throat clearing. They've seen ears, nose, throat. They've seen allergy. They come in on, nasal fluticasone already, and, everything's been worked up and Zyrtec isn't helping. And they're like, okay, well, you're actually right in the age demographic. Then sometimes their tic will change over time. We know that tics can kind of progress. Parents will often report that they'll kind of like pause one tic for a little bit and then develop a new one. And you actually, by definition, within the definition of the diagnosis, it should change with time. The repertoire of tics should change with time, especially in chronic tics. So they will have, like a physical feeling in their throat when they go to clear their throat. They'll say, there's something in my throat. I swear there's something there. Or they'll do the throat clearing, and then that feeling will get better. And you kind of hear that time and time again with other things like their neck. Something will bother them in their neck, and they have to move it and stretch it, and that feeling will go away.
What age do kids usually first present with tics?
Yeah. So usually it is ages like 4 to 7. It's like 4 to 6 in males, and then a little bit older, barely 5 to 7 in females. And it's actually 3 to 4 times more common in males than it is females. And interestingly, as you get older, females outgrow it a little bit less. And so into adulthood, the rate of tics and Tourette's is actually 1-to-1, same amount males to females. So it's more common in kind of kindergarten, first grade boys is when it often presents, and it really peaks around ages 8 to 12 is when, when parents, kind of what I was alluding to earlier is parents will say one tic will improve, and then they'll have a gap, and then another tic will develop, and they often use a similar phrase of like, it's almost like a new tic replaced the other one. And eventually what we'll see is like with time, that period of time between developing new tics gets shorter and shorter. Sometimes they'll even start to overlap, and such that like kids age 9, 10, 11, 12 will sometimes come into clinic and have like 3 or 4 different tics that really bother them. Often one is kind of has the most social stigma, and we'll ask them to kind of talk about that one the most, but they can develop multiple tics all at once. But it usually starts off as something in the face, some small movement in this face, or like a sound, a sniff or a snort. And then eventually as they become like 10, 11, 12, they can often have multiple. And then it actually starts to get quite a bit better with time. So around age 13, 14, you'll start to see tics kind of peter out. They still tend to have some of the same comorbidities as they get older, but some of the tics themselves will peter out with time.
Now, I always thought that with Tourette's, there was a lot of loud oral sounds and uncontrollable movements. Is that sort of how you would diagnose it, or what's the criteria to be called Tourette's?
Yeah. So that is something I try to dispel a lot with families, is that, again, a vocal tic or a phonic tic is just a tic you can hear. So common phonic tics might be like a humming, I had a kid yesterday who made like a pursing noise with his lips, and it's just simply a tic you can hear. Now, the coprolalia and copropraxia, those are coprolalia being kind of obscene words as part of your tic, and copropraxia being obscene gestures as part of your tics, are things that can happen. They're really, really uncommon. It's like single digit percentage of kids with chronic tics that develop those things, those obscene gestures and words. And usually if they do have that, it's anywhere from 5 to 10 years after the onset of typical tics. So it's usually much later in adolescence that they kind of develop those things. And it's really, really rare. Most phonic tics as part of a Tourette syndrome picture are things that are more like humming and grunting and things like that, or throat clearing even.
How disruptive is this in school?
Yeah, great question. I think, back to that story of kindergarten, I think every kid in kindergarten does this. So I think kids in kindergarten or first grade know other kids do these things and have a really high tolerance and don't put a lot of social stigma. And we don't see a ton of, I think, parents tend to be very worried that there is potential social stigma when they're 5, 6, 7. And my clinical experience is there really isn't. I make it part of my practice, like, okay, if parents are like, what if they're going to get made fun of? I certainly want to hear them out. And then I will also always ask the child, are you being made fun of? I personally find that the younger kids will say, no, not really. When I find it to be truly socially impacting for the child tends to be like that transition from elementary to middle school. And sometimes, kids will kind of like mimic them and things like that, which really bothers them. Or they just become more aware, or the child themselves becomes more aware. But I usually try not to talk about, going too wild with treatment, unless the child themselves says to them, it really bothers me and I'm getting made fun of. If it's simply that the parents are worried, then I usually try to just say, hey, and until they tell you, then I don't necessarily think we need to talk about a treatment right now.
So speaking of treatments, what are they and how do you proceed?
Yeah, that's a great question. The standard of care first line is one, just, counseling the family that really we don't need to probably treat every tic, and tics will come and go. And there will be times where, and both of my kids have had transient tics as well. So I will say there are times where I'm like, this is happening a lot. Like, we need to do something about it. And then it will just go away for 6 weeks or so. And I'm like, I fell victim to it. We don't need to treat them. They tend to come and go. So the first line therapy is either counseling that we may not need to treat them. You can do things. So magnesium has been found to be helpful. A little nighttime magnesium can reduce tics some. And then if we do decide to treat, we often try to tailor treatment also towards some of the comorbidities. So we usually like to kind of target things like the alpha agonist groups, like the clonidine and the guanfacine. CBIT, comprehensive behavioral intervention for tics, is also considered a first line. That's usually either a psychologist or an occupational therapist. We have several occupational therapists here who are CBIT trained, where they kind of introduce the idea of a competing response or habit reversal to kind of get the kiddo to redirect their energy to a different movement while that feeling is present. After that first line, you start getting into kind of what I think of as like bigger therapies, like antipsychotics and things like that, things with much bigger side effect profiles. Usually you can get away pretty good with several different things. I think CBIT, an alpha agonist, addressing comorbidities is if you reduce a child's anxiety, ADHD, OCD, some of those symptoms, the tics often get quite a bit better. So sometimes before I necessarily, personally in my practice, before I start escalating to things like atypical antipsychotics, I'll say, well, okay, the clonidine did help, but have we addressed your anxiety? Have we talked about your OCD? How are you sleeping? Worsening sleep often results in worsening tics too. And so sometimes my next line of treatment is to talk about some of the comorbidities rather than necessarily going into the atypical antipsychotics. But there definitely is a place for those. And we've had some kids have really great responses to those too.
So you brought up comorbidities. I think I heard you say ADHD, OCD, anxiety.
Yeah.
How prevalent is that there's actually a comorbidity rather than just the tic?
Yeah. It's almost the rule, not the exception. You can find varying different statistics in terms of the rate of comorbidities in tics and Tourette syndrome. About the highest statistic I've found is about 90% of kids with chronic tic disorders or Tourette syndrome have a comorbidity. It's probably anywhere from like 60 to 80% of kids have a comorbidity or a co-occurring condition. And so the three most common being ADHD, anxiety, and OCD. And there is even like a kind of a fine line sometimes between OCD like movements and tics that can be hard to tease out and can take a little kind of clinical nuance to decide what's a compulsion and what's a tic.
Can you reassure parents that at a certain age, the tics will be gone?
I wish I could. I can't necessarily. I do think, if you have a transient tic, the odds that they're going to have tics as an adult is probably less. But I think it's usually like once, it's like 14, 15 where I start to see a huge improvement, or those kids just stop coming to clinic because it doesn't, or both. They aren't really bothered by their tics at that point. But it tends to go away in about 70% of kids, and about 30% will still continue to have tics as an adult. And then a small portion of that even further will still need management within neurology for their tic disorders and need some medications for those. So about 90% of kids will have a pretty darn good prognosis, even diagnosed with chronic tic disorders.
That's actually an amazingly high number. Must be very reassuring to parents.
Yeah, it is. I will say it is, but the diagnosis, like if you have chronic tics, it tends to span a long time. Like if you think about kind of all those numbers I just said, like age 6 or 7, you say you get diagnosed with chronic tics, you may have them for almost 10 years, right? You may be dealing with this. And so one thing in terms of the treatment realm, not only the comorbidities and the co-occurring conditions should be in place, but almost the first thing I'll often say to families is, do you have a 504 for school? Because this is, a medical diagnosis. It's a neurologic etiology. And there are probably a lot of things that are underemployed in the school setting for kind of adapting to this or kind of making this easier on the kiddo. So timed tests. So tics are difficult, right? So let's say, for example, one thing I do a lot is recommend untimed tests or extended time on homework. Because if a kiddo with a chronic tic disorder is getting worked up because they're like, oh my gosh, there's 19 minutes left of this test, and then they get stressed out and they're starting to do more of their tics, and that's very distracting. And then their tics are making them worried that they're not going to complete their test on time. And then now it's 18 minutes and it's this vicious cycle. So just sometimes either reducing the time test or letting them take tests in a different room can be a huge strategy. And if you take this, and then again, if you take the stress out of school, all of their tics in general might also reduce. So giving families the empowerment to pursue a 504 is a big help for these families.
Where does a pediatrician come in? Do they manage this themselves when the parents bring it up, or do they eventually refer to a tic program like you have?
I think we've seen several different things. I think pediatricians certainly can manage. We've seen lots of kids come in already trying 1 or 2 alpha agonists, which is very appropriate. We've seen some that say, well, those tics, as we mentioned earlier, some blinking tics, those can occasionally be concerning for seizures. So sometimes they'll refer to neurology to say, hey, is this tic or is this seizure? Sometimes pediatricians kind of bring them to us if they want to go beyond an alpha agonist. And I think that pediatricians should feel able to do and certainly confident in prescribing one of the alpha agonists as a first line. But in terms of pursuing CBIT or talking about antipsychotic medications, we're happy to see them in clinic here. We do have an integrative tic clinic for that reason.
And what are some of the common misconceptions that both parents and providers have about tics and Tourette's?
One of the best things that I think any clinician and pediatrician can do is to counsel the family that these are movements that they cannot stop or control. It would be like, it's akin to holding in a sneeze. You can hold it in for some long period of time, but eventually starts to feel very uncomfortable. And we often tell families, like, telling them to stop it, quit it, hold still, be quiet, actually can make it quite a bit worse, because then all they're doing is saying, well, that urge is still there and it's building and building and building. There was actually some data that looked at where do tics present the most often. And the biggest one is one of the biggest ones was either during homework or like in the car on their way home from school, because like kids have been suppressing it all day and they get in the car and they just have this kind of like small tic explosion because they just let them all out. And that's very normal. So I want to like reassure families that if you get them home from school and they have a bunch of tics in your car, they haven't been doing that all day, most likely. They're kind of like letting it out in a place that they feel comfortable, which is great. Your car is safe. Their home is safe. Just let them do it. And, I think from counseling for families as well is like, if they're doing a bunch of tics during homework, like, let's take more breaks. We don't want to necessarily change the overall goal and expectations as parents around the house in terms of like, okay, you're having too many tics. You don't have to do homework, but let's, take a 5-minute break, then come back to it. Let's take a 5-minute break, then come back to it. So some of those accommodations that we sort of ask for and advocate for in school are things we should advocate at home. We don't draw attention to them. If they need breaks, we can do those things. And they're not doing it on purpose. They're not doing it to be disruptive. And they should have a safe place where they can go tic and then kind of resume back. So dinner table, if they're ticking a bunch, they can take a break for a minute or two. But then if your expectation as a family is that you eat together as a family, they should come back to the dinner table and still finish.
So Chelsey, I love the analogy that it's like a sneeze that you can only keep in for so long before you let it go. But along those lines, it almost sounded to me like the kids can control it a little bit at school. And as you said, they start ticking and tic explosion in the car. So is there some voluntary control?
Yeah, that's a great question. So it is temporarily suppressible. We've seen a handful of, we've seen kids time and time again that have said, at school, let's say, for example, I just have, seen so many kids. So I'm trying to think of exact examples. So if a kiddo is, if one of them is like a snort, which is a really common one, it's like the only thing I can kind of akin it to is like the pre-hockaloogie sound is that sound. They might do it really small and little and just do like a little sniff. So they can like either turn the volume down on it or they can like hold it in for a period of time, and they can often like suppress it. So my question to them tends to be, hey, if you had to do a presentation or it comes to you to read aloud, can you like hold them in briefly? Because that's really pathognomonic for tics too, is this temporary suppressibility. So they can definitely hold them in for periods of time. Some kids, younger kids, will say no, they just come out either way. But sometimes they can actually if you get out in the history, you can say, oh, they'll actually just do smaller ones sometimes when it's quiet time.
And you talked about sometimes anxiety bringing out tics. What about periods of like great excitement? Does that also impact tics?
Yes. So ironically, good stress and bad stress are both forms of stress, and both can, trigger those. So we've seen lots of, another time it's funny. It's not only times of stress, but it's also sometimes moments of quiet. So it's these two paradoxical moments that you can really see a lot: times of stress and excitement, and then times of quiet. And I have almost universally, this rule has not failed me, but I have my own like clinical rule that if a family shows me a video where the child is watching TV or a movie and they're trying to show me some sort of movement in their face, I have yet to be failed on this, but it's almost universally tics. Usually the kid's sitting there kind of doing all sorts of kind of funny things like this because their mind is like kind of engaged, but also not. And so it allows for the kind of the more rudimentary movements to come out because their brain is engaged in something else. So you'll see a lot of movements come out during homework and movie times.
Do kids know when they're ticking?
Not always. Some do when they get older, they're aware of a smaller number than they realize. But I think for the most part, kids don't necessarily know they're doing it until someone calls attention to that, or like a parent accidentally, kind of not in a mean way always, right? But if a parent says, stop that or quiet down, they're like, what are you even talking about? I'm not doing anything. You hear that quite a bit of like, stop what? And the kids are like, you are doing this like, snorting sound over and over again. And I will tell parents, like, it is okay to be, two things can exist at once. They can be a little bit grating to be around if you're trying to focus and do things, and that can be true. And you can also offer a lot of gentleness and compassion to the child and say, hey, I'm going to go work upstairs because I just really need to focus. You don't necessarily need to call it out exactly that like your tics are bothering me, so I have to go upstairs. It's just like, I need to really focus. So I'm going to go be alone for a second. So, and that's an okay thing to say to kiddos.
And then, Chelsey, what are functional tics?
Oh, yeah. Very good question. So during the COVID pandemic, we saw a huge increase in the number of referrals to our neurology clinic for adolescent females with a new onset of explosive tics. Looking back on it, it was probably considered probably a sociogenic phenomenon. Functional tics are a different set of tics. As opposed to coming from sort of the movement part of the brain, the functional tics are coming from more of the mesolimbic or the stress response of the brain. So they would fall into a classification of disorders called functional neurologic disorders. And we have a handful of different functional neurologic disorders, such as functional weakness, functional seizures, and there's also functional tics. And this was something that spread a lot during the COVID pandemic, likely in response to, in part, how much time everyone was probably spending on social media, because there were a rash of these videos being shared on social media of large amplitude, kind of big tic movements. And a lot of these kids were presenting to clinic with almost those exact same tics as well, not necessarily doing it volitionally or malingering by any stretch of the imagination, but rather that this was kind of a stress response, maybe to being the COVID pandemic, to just being a teenager. But we see they're a very different subset of presentation. It's a very different presentation than a typical tic. So while as the typical tic is ages 5 to 6, it's like the onset is like, oh, you can't really, I don't know. It was like maybe first grade or second grade. And it started in the face and kind of went away. And then it was like 5 years later before they started making any bigger noises or sounds. These kiddos are presenting in adolescence for the first time often. And it's more often females than males, which is kind of different. And they're presenting oftentimes with multiple tics all at once and very different, as opposed to rostrocaudal distribution. It'll kind of start in the arms and it'll start with noises, and they'll often have variably produced tics as well. So for example, I saw a girl in clinic that said, one of my tics was I hit the roof of the car when I'm in the car. And I said, well, what happens when you're not in the car? And she's like, well, then I don't do that one. And I'm like, well, tics organic tics aren't necessarily affected by your surroundings. You kind of do them wherever. But if you have tics that only present in certain locations, I think you have to suspect a functional tic-like behavior. These kids tend to do well compared to adults. Functional tics in children do better than functional tics in adults. And we actually see an increased chance of, or an increased rate compared to adults of kids with organic tics and functional tics. So I think really kind of taking a lot of time to go through the semiology of the tics and what they look like and when they presented. And again, that acute onset of very large amplitude, very complex motor and vocal movements is most likely to be a functional tic-like behavior as opposed to an organic tic diagnosis.
What's on the horizon in terms of research?
Oh, there are a number of studies right now. I know that there's a medication. I'm forgetting the name of it right now, but I think it's a huge area. DBS is something that's used a lot. Deep brain stimulation is used a lot in adults with chronic tic disorders. It's not used as much, and I think there's a lot of room for that as well. I think looking at, newer medications and things like that, and technology as well. So tic watches and other things like that can be helpful for the day-to-day with some families.
Well, that's exciting to know. What are the 3 takeaway points that you want people to know about tics and Tourette's?
Oh my gosh, I only get 3. I would say, oh my gosh, what would I say? So for tics and Tourette's, I'd say the comorbidity rate is very high, and sometimes treating the comorbidities can be as effective as treating the tics. I would say number 2 would be not all tics need to be treated. They aren't necessarily, unless they're causing pain for the child or a lot of social stigma, they don't necessarily need to be treated. And then I would say 3, I'd probably come back to the functional tic etiology, because we still see this in clinic. And I think I saw one last week. Functional tics are a different subset of the population. It's important to have that conversation early, as we do know that all functional neurologic disorders, the prognosis is better if the diagnosis or the differential that this may be a functional tic or a functional neurologic disorder is brought up earlier. Those kids tend to do quite a bit better when you bring that diagnosis up early. So continuing to be direct, if that's part of your differential, is that this might be a functional tic, then those kiddos tend to do better if you just bring it up earlier.
Is there any intellectual disability associated with tics or Tourette's?
So we do know that tics and Tourette's are slightly more common in those that are neurodiverse or have developmental differences. But for the most part, it's not a very high rate, meaning that like if a kiddo comes with tics, I'm not asking necessarily, but is school okay? Like I don't necessarily assume. I actually find that all 3 kids that I saw yesterday in our Integrative Tic Clinic were above average for school performance. And even with these tics that are happening day to day, they're still kind of able to do above average. Sometimes tics are so common that their grades do not sustain, and they do kind of go backwards a little bit because they're so distracted. But then you also kind of have to keep in mind the comorbidities. Is it also the anxiety? Is it untreated ADHD? So it really is kind of looping in the PCP and kind of looking at what other ways they can be supported too.
Chelsey, thank you so much for spending some time with us today, sharing your vast fund of knowledge. I've learned a lot, and I hope that everyone listening has too. And until next time, keep on keeping kids safe out there.